Hi, everybody. It's Karen Anderson here with Aortichope, and this is our final live event for September Aortic Disease Awareness Month, and it's always a great one. So can I say we're saving the best for last? I would say it, and part of me feels that way because you're so near and dear to my heart, but we have had such great live events this month, but we are so happy to have Dr. Stacy Fisher with us tonight. And I'm just going to let you take a minute and tell everybody a little bit about yourself.
Sure. So I'm Dr. Fisher. I run the Adult Congenital Heart Program, the Women's and Complex Heart Disease Program at University of Maryland. My training was in adult primarily cardiology, adult medicine, and then adult cardiology. And then I did about a year and a half of pediatric cardiology focused on the care of adults. And I run the cardiogenetics program at Maryland. So I have the privilege of working with people who grow up with structural heart disease and many people who have genetic types of heart disease or things that may run in families that many of the people here in Aortichope have. And through that, I've gotten the privilege of being part of the Aortic Disease Center and working with both vascular surgeons and cardiac surgeons in the care of patients with aortic disease. And I hope to try to add the medical aspects to that.
That's a great explanation. And this will lead me into asking my very first question. And just to remind everybody who happens to be watching with us live, we're just going to chat here a little bit. I'm going to try to address some of the issues and questions that I see and read about in the community. And then we're going to open it up for questions from the audience. So I think there's a little bit of a confusion, of course, with people who have had a dissection. Maybe not as confusing with people who are watch and wait with an aneurysm as to what the role exactly is of a cardiologist. In these aortic disease teams, we have our surgeon, which if you've had a dissection, you know them first. And then sometimes you're told about a hypertension specialist and a vascular specialist. Hi, puppy. So what exactly does the role of a cardiologist play?
So the cardiologist is somebody who will evaluate the heart aspects and also blood pressure and risk factors that may go into aortic disease. So the cardiologist may be the person that helps to figure out if something like an aortic aneurysm or dissection is related to things like a valvular heart problem, like a unicuspid or bicuspid or quadricuspid aortic valve. The aortic valve normally has three leaflets. And some people have 1, 2, or 4, and then the tissue is weaker around that, and they can be more prone to aneurysm change. So that's one thing that they can be a part of. They are generally a primary part of immediately the blood pressure control, and over time control of things like plaque and vascular disease, screening other areas such as screening for brain aneurysms or aneurysms that may affect other vessels.
Okay, so for those of us who have had a dissection and maybe never met with a cardiologist before and you come out of this surgery, it is obviously highly recommended to find a cardiologist because I know some people, they end up getting a lot of these medications through their primary care. And so that's been a question I've had. I'm of the belief when you have a specialized situation, that's why you go to the specialist. I'm not knocking primary care physicians, but I guess I want to help the community understand the role and the differences there.
Yeah, I think it matters who's available on your team where you are. So it can be very different across the country and across internationally, like who actually has the ability to do this care, has training or special interest to do this care. Some areas may have a genetics person that a particular family will work with that works with giving recommendations for surveillance, recommendations to deal with other areas of the body. For example, with Marfan's disease, you should have screening of the eyes. There's some skeletal screening or screening of the spine that should be done. So that it could be the genetics person giving some of the recommendations, but your primary care person may be the person doing your blood pressure management and dealing with that. And you may have a vascular surgeon that's doing all the screening. So if you have that, you're really covering all the areas.
Okay.
Some people also have things like heart palpitations, family history of coronary issues, aortic plaquing, or aneurysms, other places where they actually really need a cardiologist input. So I wouldn't leave a blanket statement that if you have aortic disease, you have to have a cardiologist. You have to have a team that can address the varied problems that can go with this and that can look for the etiology and make sure your blood pressure is controlled. Some people have very easy to control blood pressure, and some people really have refractory high blood pressure that needs special thought and combinations of medications that maybe a cardiologist is more comfortable doing.
Because you are jumping right into my favorite topic with you, which even after 7 years, I still learn something new every time. And that would be your blood pressure 101. And when I say this is a constant topic and cause for concern, it's because there's always new members coming into the community, which is a good thing that they're able to find us. You know, it's unfortunate that people end up having aortic disease, but if you could help people understand really what's happening with blood pressure, and then if we can just get into a easy lesson a little bit about the changes in blood pressure and medication and what affects it, and all of the things that we talk about all the time in office and online here.
Sure. So blood pressure is one factor that if you have a fragile aorta, controlling the blood pressure can really take a lot of the work off of the vessel, and it can help slow down any process of the vessel getting weaker against pressure. Not everybody in the group has high blood pressure. Some people actually have very low blood pressure and actually need to maintain enough blood pressure to function and not be dizzy when they stand up. So you want to maintain a normal range of blood pressure. High blood pressure is very common in the US specifically, in part because we have a high salt diet. So salt is one of the biggest things that immediately increases pressure. So for example, if we meet somebody who has very low pressure, salt water will bring the blood pressure up. So reducing the salt will bring the blood pressure down, especially that bottom number. And that bottom number is really what puts pressure back on the valve. The aortic valve is as blood goes forward, you want the valve open. As blood goes backwards, you want the valve closed. And you want to separate filling in the heart from ejection in the heart. So you want it to go forward, but not forward and back, forward and back. So that bottom number puts pressure backwards. So lowering the salt really helps that bottom number. There's a lot of categories of blood pressure medications. When you look at taking the pressure off of the vessels, the primary ones that we focus on are the beta blockers, which lower the heart rate and the wall stress of the aorta, and the angiotensin receptor blockers or angiotensin converting enzyme inhibitors. And those actually work on a neurohormonal axis that is mediated through the kidneys. The kidneys will actually see a certain amount of flow and have a hormonal response that affects the pressure that the body is set at. So if the flow to the kidneys is weak or the vessel is a little bit tight, you're going to raise the blood pressure to get more flow to the kidneys. These medicines can help relax that area. They help relax the vessels. The other thing is that a side effect of certain drugs in the ARB family, specifically irbesartan and losartan, give you a little bit of the fibrillin gene product. So specifically for Marfan's patients, that may be one of the first directed gene products that can actually help stabilize and strengthen the wall of the vessel. So that class of drugs is very attractive for that particular group of people. There are many other medications generally that we use primarily for their blood pressure effect as additive medicines. Some of them have benefits for different people. For example, calcium channel blockers may help more in African American patients to bring the blood pressure down more. They are also used sometimes for migraine treatment. Some of them lower the heart rate, some of them don't. There's a couple of classes of those. And when we still have high blood pressure, we always need a diuretic of some sort to try to balance the salt intake. So people excrete salt differently, and that's part of how the salt ends up contributing to the high blood pressure.
Okay. So when we leave the hospital, some patients are told that they should immediately go out and get a blood pressure cuff, and others are not told this. I guess some doctors don't want patients to worry about their blood pressure right away and just focus on healing. If we get a cuff, how different is the wrist from the arm? How significant of a difference would your readings be?
Well, the wrist blood pressure cuffs are just not as reliable. They shouldn't be very different at all. The arm blood pressure cuffs are a more reliable product at this point in technology. And there are some finger cuffs that I think have a terrible reliability, or they're just not very well validated.
Okay.
But generally the arm blood pressure cuffs are well validated. The main thing though is that you have a cuff that fits your arm, and there will be markings on the cuff. You can actually measure the circumference of your arm and the distance from your shoulder to your elbow. What you really want is something that's 3/4 the distance between the shoulder and the elbow. The fact that it wraps around more or less doesn't matter so much as long as it doesn't pop. But you're really worried about the distance between the shoulder and the elbow. So you want to make sure that's a reasonable distance. And that will give you a good blood pressure reading, or a reliable blood pressure reading. So the way that those cuffs work, you put it on. You want to rest your arm. You don't want your arm exercising. So when you're holding your arm up, your arm's essentially exercising. So you want to rest the arm. So the position is not that important. What's important is that you're resting.
Okay. Okay. And some people have indicated in the community that they find a difference between their arms. Why would that happen? When should we be concerned? And then which arm do you want to consistently take your pressure off of, pending any restrictions you might have?
So naturally, there really shouldn't be a difference between the arms. If there is a dissection involving the vessel to the arm, it's generally the vessel to the left arm, because the way the tear can spiral around, it can affect the blood flow to the left arm. So when we're trying to look and diagnose a dissection, one of the clues may be that the left arm blood pressure is lower than the right arm. And in people who have a congenital condition called coarctation of the aorta, often the left arm blood pressure is lower than the right arm. So that's actually really important to see. So if you're looking to try to compare, you want to know, basically leaving the hospital, what is the difference? What does it generally run? And if you're getting something that's way off from that, then that's where you want to talk to your doctor, or even consider repeat imaging. The left arm blood pressure the arm can tolerate a fairly low blood pressure, but just like the rest of the body, if it's not getting enough flow, you may get angina or symptoms of not enough blood flow. So you may, with use, find that your arm gets heavier, tired, or aching. And that can happen if the flow to your arm is low. So if the tear has really compromised flow to the arm can try to get collateral vessels over time. But if it's really bothering you, rarely they have to bypass the flow to the arm so that you get enough flow to your arm.
Okay.
So that's more of what we're worried about.
Right.
It's more the diagnosis. Do you need repeat imaging, and is your arm okay?
So if you're home and you just happen to take your blood pressure, is there a difference in which you're saying any difference you should let your doctor then know?
No, you're probably, if you have a difference, you're probably going home from the hospital with it.
Okay.
And you probably know that on your way home. You should ask that when you're leaving the hospital or at your doctor's office. Is there a difference?
Okay.
And then you're always going to have that difference.
Okay.
So you don't have to let them know every time you measure a difference. You have to know what the difference is and know if it's changing. For treatment purposes, though, it's very important to follow the right arm or the higher blood pressure, because you want to follow the side with the normal flow. And that's how you're making a decision of what is the head seeing, what is the heart seeing, and what is the body seeing, so that you can make good treatment decisions.
And then the question comes, your blood pressure runs differently morning, noon, and night. Is there an expectation of a time of day that it would be higher? Is there a better time to take it?
So generally your blood pressure is highest in the morning. even though you wouldn't think that, even though you've had a great night's sleep, but there's a natural circadian rhythm, and that's what most humans have. The medications can certainly alter that. Certainly lifestyles can alter that, but your natural rhythm is going to be highest blood pressure in the morning. The blood pressure should not be a flat number. If it's the same exact number all the time, then you're probably over medicated. You really want your body to be able to have a range, but that range should be a reasonable range. So what your best outcome would be to make a log, time, date, pressure, and check it occasionally in the morning, occasionally in the evening. If you're seeing a time you're concerned about, get a few measurements on different days, a few weeks apart, because what you're really looking for is lifetime changes. And you want to mediate this. And if you're seeing the numbers are creeping up, the first thing to ask is, what could I do lifestyle-wise to get it back where it was, and why did it change?
Mm-hmm.
So sometimes that's stress, weight, salt. If you haven't slept well, certainly things that you could do to hurt the blood pressure would be things like ibuprofen. Ibuprofen can really, or naproxen can raise the blood pressure, any of the NSAIDs. We don't like you to take pseudoephedrine or Afrin nose spray. Those are things that can instantly raise the pressure and also constrict the vessels, which is terrible for a dissected vessel.
Okay. And that's good to know as we're getting ready to move into flu season and we're still in the thick of COVID. If you are feeling those cold symptoms, you're saying that, so am I right that the better medication over the counter would be quercetin?
Yeah, quercetin's good, or anything that has the DM, that's going to be okay. The NyQuil is okay, but not the Dayquil. Tylenol is okay.
Okay. And just saline in the nose, not Afrin.
Saline in the nose is great. And also, not for a cold, but if you have allergies, you can certainly use like the Flonase or the Nasonex, or even nasal crom, which is an antihistamine. It's actually nasal cromolyn. So that's kind of a unique product that may help certain people with allergies.
Okay. And if you
allergy pills are okay.
Okay. Like Claritin.
Not with the Sudafed.
Gotcha. Okay. Now, if you've been exercising, how long should you allow yourself to recover or rest before you take your blood pressure again?
Just 5 minutes.
Okay. But it should recover. Okay.
Yeah.
Okay. All right. So we have talked about the two different types of patients. You're going to have your people that have watch and wait aneurysms, and then people have already had dissections. I know some of the questions that people have would be the different types of tests that a cardiologist or a surgeon would order. You want to go into those a little bit?
Sure. And first of all, I've never heard the term watch and wait aneurysm.
Oh gosh, yeah, that's big here.
Hopefully some of them are actually very stable indefinitely and never need anything.
I think that everybody just sits here and they think, once they get it, we're watching and now we're waiting. And I think you're right. Maybe we should just do away with the wait and just we're being monitored. I mean, because that's what you hope for, to be monitored anyway.
That is what you hope for. We do try to be realistic that if there's changes, you want everybody to know to expect a recommendation to have it fixed, because it's a big recommendation. And I think if you can wrap your head around the idea that it's something that you may need to address, it's a lot simpler to deal with the fact when it comes up that you need to address it. Yeah. But there are a lot of people that just have dilation that doesn't really change over time, or maybe they really have it because of high blood pressure and get the blood pressure controlled. Maybe they have untreated sleep apnea, start treating it, and their blood pressure is now perfectly controlled. All the wall stress is gone and it just stays the same. But there are many people who progress, and you definitely want to look. Mm-hmm. So now I forgot the main part of the question.
That's my job to forget things. That's not your job. But it's been a long day for you. So I must say right now how much I appreciate you hopping on at this time of night. What would be some of those tests that patients would have from OnStart?
Sure. So one of the simplest tests is called an echocardiogram, which is an ultrasound of the heart. An echocardiogram can see the muscle of the heart, the valves, and the aorta. Some people we see better than others. The picture coming from here, from just above the neck, looking down at the aorta is a picture taking, is a way to take pictures of the root and also the arch and descending. So again, we can see better in some people than others. If we see well, we can tell that we're seeing. If we can't see well, we can't tell that we're seeing well. So some people, depending on where the aneurysms are or what the concern is, you can see better than others. The other ways to see the aorta more fully would be either CT scan or MRI scanning. So an MRI scan is a way that reads the body's magnetism. So you're actually in a scanner where we look at the body's magnetism and we get pictures of the vessels themselves. And you actually get a full 3D reconstruction of those pictures. The MRI does not have iodine contrast dye. It has a dye called gadolinium. Gadolinium is a magnetizing, it's like sensitizes to the magnetic. So it is a fairly inert product. So if you have kidney issues, generally this is a better product. If you're pre-dialysis, then we still really don't want to use the dye, and we end up using the non-contrast studies. Or if we really need the contrast, we use the CAT scan and just try to use the least we absolutely need. The CAT scan is a way to actually make serial images and slices. They can go down to less than millimeters and then reconstruct the vessel. That requires an iodine contrast dye to actually shatter the inside of the vessel and get a really good look at the vessel itself. That iodine contrast can affect the kidneys if your kidneys are fragile. If you have normal kidneys, it would be really unusual or unheard of for it to be an issue. But most people feel very warm when the iodine contrast goes through. Some people say they feel like they went to the bathroom even though they didn't. It's just a very warm flush that you get when the contrast goes through. But it's quick, it's not a lot of dye, and it shows us the vessels really well. And that may give us the finer detail. So that is a way to actually see it. And again, you can get a 3D reconstruction where the echocardiogram in general is a two-dimensional study.
So are you going to find great differences in measurements between those three different studies?
So the echocardiogram is a good screening tool, but if you're seeing changes, we go to either the CT or MR for confirmation. The CT and MR should be very interchangeable. The issue with measuring an aorta is it's like a candy cane. It really has that shape. And if you're trying to compare one scan to another, we try to pick spaces that have landmarks, like around the pulmonary branches or right at the sinuses, where we can actually measure and compare year to year. But we also try to measure the biggest spot. And that spot can be a little bit of an oval measurement. So 1 or 2 millimeters can just be reader variability.
Okay.
I'm just going to shut this door real quickly.
Sure, no problem, no problem.
Said it too hard.
No, that's okay. One of the other things that we've talked about before, which was another terminology you hadn't heard of, was pings and pangs. That we all have to look after we have a dissection. This is really mainly for the dissection patients. We're trying to get a feel for what our bodies feel very, very different. They do not feel the same as it was before. I can assure you, I don't think I've ever met a person who's had a dissection, A or B, that has said that they didn't notice there was a change in feeling their body. And sometimes it's the way that the valve or the heart's been repositioned after surgery. You just feel things differently. And on top of that, you have medication and you're emotional and what have you. So the problem can be when we feel that ping or pang, whether I know somebody out here is going to be watching, laughing at me, because I always say it could be gas. Now, I'm not here to guess anybody's situation, but sometimes gas can get trapped in the chest and it hurts really bad. But other times you don't know what it is and you're flashing back and you don't know, is this it? Should I go to the ER? So we try to help the community start the conversation with their own doctor to determine what works best for them, because I would never tell somebody not to go. I would never tell somebody, to do anything other than go get something checked out. But what would you recommend the community do to handle the weird sensations we're now feeling or the discomfort we're feeling?
So first of all, just like you said, your body's different, and some of it is a matter of getting to know your body again. Everybody, immediately after surgery is going to have some surgical discomfort too. And getting used to that and discriminating that can be terrifying also. So the first thing is, if you can push on something and reproduce it or get in a position that makes it go away, it's okay to call that muscular. And that type of pain, if you think back, you had before your dissection too. If you're gonna rehab your body and you're exercising your muscles and they're sore, and they may be very tender because you're rebuilding things that were cut. So, so if you can push on it, reproduce it, and get into a good position, it's okay to call it muscular, right? It's also okay to have a Tylenol or to put some, Vicks Vapor Rub menthol on it, or a lidocaine patch. That's fine. But you don't have to think that that's your vessel or that's cardiac. If you have a ping or pang in different places, usually that's anything from nerve firing as they repair themselves, or you can even have secretions that you cough up and then that area feels better. If you have something, especially in lots of different spots that last under a minute, it's fine to ignore that too. So kind of deciphering what you can ignore, what you can't ignore. So if it doesn't have a pattern, it lasts under a minute, or it's reproducible, those are definitely, I can ignore that and go on with my life, and I don't have to think I'm going to burst. If you can also try Maalox or Pepcid AC, a fast-acting antacid, or if you don't have any of those, you could do a teaspoon of baking soda and see if it's gas or reflux. Because also, having this is going to increase your stomach acid. A lot of people get stomach upset, heartburn, and that can actually mimic anything. And you can get a cramp in the esophagus, just like any other muscle that feels terrible. But if you can take something like that, warm water, Maalox, Pepcid AC, baking soda, and it goes away immediately, then it's okay to call that heartburn, and then to discuss heartburn with your doctor, look at what you've eaten and see if you can modify that, and that's great too. If you can't tell and you're getting a pressure in a particular area here or here, something that, especially if it radiates through the back, but something you're really not sure about and you just don't feel right, it's much better to go to the emergency room and get checked. You can call your physician and see what guidance they have. Sometimes we've had people that were just checked and they're still having difficulty. We may bring them into the office and do an echo and see if we can see the area they're concerned about. But generally, if you're having a persistent discomfort, we would like to get a new scan and make sure there really aren't changes at the repair site or around it or in another area.
Pings and pangs, the struggle is real.
Yes, and there may be emergency room visits, and you know what? That's what the emergency room's built for. Exactly. In the pandemic, I think we had too many people that didn't come in because they were afraid to get care. And we're seeing now, even today, I'm covering the intensive care unit at university, and we see people that just come in too late because they were too afraid to get care. And the injury is lifetime after that.
Right. And that's a nice.
Much rather you come in, get checked out, be okay, go home, maybe be a little tired and grumpy. Next day you'll be fine, but you're fine too.
Right. And that's a really great transition into another thing I wrote down here. I have two other things after this I want to talk about before we open it up to see if there's any questions. Is COVID, and this is not to bring up anything controversial. This is factual information, and I think people in the community really would like to know because when people say, well, people that have aortic disease are at risk. And it's not that we're at a higher risk for getting COVID. COVID doesn't see us and say, oh yeah, you have aortic disease, I'm going to jump into you. it's the higher risk for the complications and and just the stress the body's going to go through to rid itself of this virus. Can you talk about that a little bit?
Yeah, I can. And some is real and some is perceived risk.
Okay.
So COVID is a nasty virus, right? No, we all want to avoid it if we can. We definitely want to get immunized. There is no reason that aortic dissection should keep you from getting immunized. If anything, it should be the reason you do get immunized. So that's actually really important. If you have a clotting problem, then you should get one of the mRNA vaccines. So that's actually important. We have found with COVID that the major risk factors for severe disease are age, immune suppression. So if you're on biologic medications or prednisone long-term, or you've had a transplant organ and you're on medications to keep that transplant organ from rejecting, those are risk factors for severe COVID. Other risk factors are diabetes, especially with poor control. So right now would be a really important time to make sure your sugars are well controlled. COVID likes heaviness, it likes fat, it likes weight. So really that is one of the bigger risk factors. So diabetes, age, hypertension. The hypertension is very interesting. It increases certain ACE receptors. And COVID actually attaches to these ACE receptors to get into the cells. Hypertensive people, especially if they're not controlled, have very high levels of these receptors, and they get very high viral loads in their cells. So it sets you up for severe infection. So those are the bigger risk factors. The other thing is your functional status. So if you are able to do a lot and you're physically active, you also do much better. So those are the big risk factors. We do believe that people that have had underlying trauma like lung injury from surgery or from bleeding into the lung, asthma, those are moderate risk factors for COVID. And COVID definitely has a lot of clotting issues with it, a lot of inflammatory issues. About a third of patients have changes in the heart muscle transiently, something called myocarditis. Even a third of like healthy football players that we MRI'd without any symptoms have changes in the heart muscle that make us worry about their risk of sudden death during COVID. And that normalizes several months later. So we worry when you have abnormal vessels that you'll be at more risk. We have not seen a huge difference in the survival though, except by those risk factors in patients with aortic dissection.
Okay. And again, for anybody who feels that they're having any issues within their chest, whether it's they think it's their aneurysm or dissection, regardless that your hospital might be overflowing with COVID, you're better off to go in anyway. They don't put you with a COVID patient in the ER typically, so you're going to be in a separate area, but it's always better to be checked out than to have a catastrophic event happen in your home. So I know I heard you say that. That's important. The other thing I wanted you to talk with everybody about is we had mentioned briefly in our last conversation was the 3D printing.
Yeah.
So what is happening with that? Because we hear little bits come out in the news here and there, but it's never anything that's ongoing. So what's happening with the 3D printing? Talk about that.
Yeah, so I don't think that there's anything formal going on across the world. In our own program, for example, we have a 3D print lab, and we are printing models that will help the surgeons to have better outcomes. So we will take somebody's CAT scan or MRI scan, actually print the exact size model so that they can double check the sizes and shapes of things like endovascular procedures or see exactly where a branch comes off to make sure that everything they're doing fits perfectly. So that's actually very helpful. We would like at some point to transition into tissue printing. And the issue with tissue printing is that the matrix materials are not really worked out at this point. So we're trying to work on getting something that will make a new matrix where your own cells will grow and replace the torn or damaged tissues. But we're a long way from having that in people. at the same time, it's coming. We think it's coming.
Sounds exciting.
We're working on that. So 3D modeling is very helpful in trying to make surgery safer. One thing that can't be done is it can't be done too quickly. So again, when you say like the watch and wait, part of what you can do watching and waiting is if there's structural planning that needs to be done for a particular aneurysm, you may have a much better outcome by having that time.
Okay, which makes sense. You've got time because you're waiting and watching. So if you have a physician and they're doing that, that would be kind of exciting to plan beforehand.
Right, and there is a lot going on with endovascular repairs rather than surgery, which really can't be done in an emergency situation. If it's torn or bleeding, they can't do that. They don't have the time to do the planning and imaging that it takes to do it through a catheter.
Right. One other question before we open this up, and this is only because it was just talked about today. Are there any restrictions when it comes to flying? Because I know some people do become affected after they've been in the air. I mean, I know personally me, I've got about 2 hours before I start feeling my heart really pound, or I get some palpitations. For others, they can last a little bit longer because we know we're at about, 8,000 feet is what the cabin's pressurized. And I'm not going to the top of any mountains anymore. I struggle too much. But you one time told me, Karen, people dissect and live on the top of mountains. And so it's okay. And you're like, oh yeah, I didn't think about that. Are there any issues for people that have had dissections or aneurysms around flying or going to the tops of a mountain?
Yeah, so one thing is that people may be more or less sensitive to hydration and also pooling. So gravity, when you're flying or high, gravity pull is higher. So the gravity force is higher. Everything's going to be pulled down. Your blood volume will be pulled down towards your feet or toward whatever part's dependent. So if you're laying down toward your back, if you're standing up towards your feet. And what that does is it leaves less up top. So if you're a little bit dehydrated, if you're on diuretics, for example, if you were trying not to pee on the airplane, maybe 2 hours in, then what we do, right? So you can get really dry, and you still need to get enough volume to keep blood flow going up to your head, or you can get dizzy and you can feel horrible. So gravity on top of a mountain or on a flight, number one, there's a lower oxygen level. And number two, there's a strong gravity pull so that everything pools. So if your vessels in your legs are a little bit weak, you may have a little bit of ankle swelling and feel dizzy because the blood volume that you need in your head is actually in your feet. So the way to deal with that, number one, is to wear compression socks on the plane. Now that athletes like compression socks, they're better for everybody. So they are the same as the vein support socks that they're using for muscle support. And you can order them on Amazon. You can get them at almost any drugstore. But they're just called compression socks, and they go up to the knees. They're fairly tight, but they should be graded so that there shouldn't be a line. You shouldn't end up with a sock line. You should end up with like a nice smooth grading of pressure on your leg. And that helps keep the vessels from pooling and filling up with blood so that it stays on the top of the head. And then drinking water all the way through the day before you fly or the day before you go up on top of a mountain, you should really hydrate. And that can make a huge difference in your tolerance of the process.
And there's my learn something new every time we talk. There it is. I took notes. I definitely took notes because I just thought that I felt dry because the air blows on me really hard. I had no idea, and I really could not understand why. I yawn more. I yawn most of my flights. I just yawn. I constantly have to yawn. You solved the mystery for me. Thank you. Good. All right, I'm just going to go check and see if we have any questions or comments tonight. Okay. I'm going to say hi to Kurt, Greg, and Velda. Hi, everybody. Thanks for joining us. Okay, well, our first question is, do physicians ever withhold information from their patients to spare them the shock, or maybe in thinking it's in their best interest because they might be able to, let's say, recover better?
So I have to say that in the United States, it would not be typical for that to happen. If you have somebody that is delirious and doesn't really know what's going on or where they are, we try to do orientating questions to try to figure out if they're actually okay. So you guys have probably all heard the questions, who's president, what's your birthday, do you know the name of your child? Sometimes we're probing to figure out with the medications and everything going on and everything's so overwhelming, or somebody may actually have a cognitive or a psychiatric issue where they don't know what's going on. We may not actually be able to tell them directly what's going on because they don't have the capacity to understand. Otherwise, in the US, it's really standard to be transparent.
Great. Okay.
There have been points in history, I think, where people took a more parental approach and told people just what they need to know. But I don't think you're going to find a lot of that in this day and age.
Okay. All right. Next question. And the next question is, what would be the seriousness of an infection in a stent graft?
So an infection in an artificial tissue is very serious. And it's very serious because it doesn't usually clear up with antibiotics. So if you can clear it up enough with antibiotics, you usually need to stay on a lifetime antibiotic dosing to keep it suppressed, because we never think that the artificial tissue actually is completely cleared. So it can result in the need to actually take that out. And some places we put tissues in are very hard to take them out. So if it's an important area and hard to get to, the risk of taking it out may be more than the risk of long-term antibiotics. But at the same time, if you could completely clear up the infection, you'd like to. So some organisms are harder to clear up than others. Sometimes we're more sure than other times that the artificial tissue is actually infected. But if you're getting persistently positive blood cultures, then you know that you have bacteria or yeast or whatever showing up in the blood cultures in the vessel, and the graft is in the vessel, so it will at least be exposed. And again, some organisms are definitely more damaging than other organisms.
It's an important question. Thank you. Another question? Hi, Tammy. Tammy would like to know, what is a cardiac calcium score and who gets those and why? That's my addition to that question.
Okay. So a coronary calcium score is actually a really cool test. So it is a CAT scan with no contrast. It is done really to look at your risk of coronary disease. So basically, you're looking at how much calcification of the vessel you have had in your lifetime. So when people develop coronary disease, generally they have soft plaque, which is lipids and inflammatory cells, some blood cells. They get into the vessel wall and they cause injury to the wall, and as part of the healing, it calcifies. So if you're 20 years old and you want to know your risk, you may have a little bit of soft plaque, but you're not going to have hard plaque, calcium, or injury to the walls, and that calcium score is not going to be very helpful. The time that's really helpful is if somebody is at risk for coronary disease but does not know whether they have it or not. They have a family history, maybe they have a mildly elevated cholesterol and they don't know whether to treat it or not. They have some borderline risk factors and they want to know if they need to be super aggressive with medications or whether they want to take some time with the lifestyle alone and see if they can get it under control. And that can really help to discriminate where are you at this point in time. So generally we use it for people, say 40 and older. that have indeterminate risk, where it might change their course. So the score may be 0, which is fantastic and means a very low risk of a coronary event, or even having coronary disease at that point in life, or the score can be very high. So scores of 400 or more often correlate with somebody that has a blockage in a single vessel, and a score of 1,000 or more often correlates with blockages in all of the different vessels. Just to give you some idea of what the number range is. If you know that you have blockages in your coronaries and you've had bypass surgery, or you've had a heart cath and you know exactly what's in your coronaries, then there's no reason for a calcium score, because you already have more information than a screening, right? Because it's really just a screening.
I was going to ask it, I was going to say, we're going to talk, but you just reminded me, I've already had my catheterization and everything. Nobody told me I had to worry, because, I'm sitting here, I'm like, oh God, maybe I should have a calcium screening, because my father has.
So again, if you either know that you do or don't, because you've had a heart cath or you have coronary disease, then you're not going to get any new information from this.
Right. Okay.
If you're not sure and you're in the middle, that's where it's very helpful. Often insurance does not pay for the calcium score. They still consider it an experimental study. Not very experimental, but it's also just not accepted exactly which people will get the most benefit out of it.
So if you had a higher calcium score, but you're otherwise healthy, blood pressure is under control by medication, would you recommend somebody having just a regular CAT scan? What would be the next test, just to kind of take, if they passed a stress test, they're, everything else, all other things considered, blood test is pristine, blood pressure's under control, would there be a reason, if you had a higher score, let's say in the 600s, to have any other further testing?
No, really, if you say you have a score of 600, you want to focus on the primary prevention, right? So you want to do a stress test to make sure that you don't have a functional blockage, because that 600, you don't know whether it's all on the outside of the vessel or actually blocking. So a stress test or a functional test will pick up 60 to 80% or more blockages. So if all of it's 20% blockages, you can have a perfectly normal stress test with a calcium score of 1,000 with plaque in all the vessels. But if they're all getting enough flow and have enough reserve, you're going to pass your stress test. So putting those two together is very helpful. So then you know you have disease, but you know it's not blocking more than 60%. So you need to keep it that way, because you're not going to be able to get rid of it.
Okay.
So you focus on really aggressive, so if your number is 600, you really want to get your LDL cholesterol down below 70, where if your number was 0, you want to get that number down toward 100.
Okay.
Right, to try to maintain it and not have progressive problems. You want to get your HDL up, you want to get your triglycerides down, you want to get your blood pressure down. You absolutely don't want to smoke or have secondhand smoke, no nicotine products. You want to exercise, you want to get your weight right, you want to get your sleep right, you want to address stress and get stress external to you. So you really want to get your risk factors controlled, and beyond everything, you want to get a really great diet.
Mm-hmm. Okay, very good to know. Do we have any other questions? Okay. Do you know of any websites where people can obtain any resources on doctors in their area for a second opinion, or would you say just Google cardiologists or surgeons in your area?
I think it matters what the question is. So for coronary disease, you want a cardiologist that regularly does coronary disease. If you have Marfan syndrome, there's a Marfan's group, a specialty group. For congenital heart disease, people that have unicuspid or bicuspid or quadricuspid aortic valves, then you may actually want an adult congenital physician, and there is an adult congenital heart association with a travel directory that lists congenital providers that have been board certified in that particular process.
And then if you're someone who's had a dissection, but let's say you're not getting all of this wonderful in-depth information, are there specialists, are there special cardiologists that deal with that?
So in some regions, they have aortic disease centers where they may have a group of vascular surgeons, cardiac surgeon, cardiologists, hypertension people or medicine people, and genetics. So there may be something like that in your region, and you can look for aortic disease center. You can meet with just a general cardiologist, but it would be an appointment to consult and get a second opinion. So you would make a second opinion appointment with a physician. I don't know of a number you can just call and kind of run your case by. Most of the physicians are going to want to actually see your imaging, your data, so that they can give you a thoughtful response. If your question is, I'm getting abnormal readings of my scans, and I don't know whether to do something interventional with it, then you're going to want to meet, if it's in the ascending aorta, with a cardiac surgeon, anywhere else in the aorta with a vascular surgeon.
Okay.
And you're going to want to meet with the surgeon themselves, and you may want to look at somebody who also can do the interventional procedures, so that they're not only offering you open surgery if there's a way to avoid that.
Good question. Good follow-up question. Okay. Any other questions? Tammy wants to know if you support the Mediterranean diet.
I think that's a phenomenal diet. It's all healthy fats, olive oil as the base, lots of lean and green, healthy greens. So none of the white grains are in that diet. Lots of lemon. Very, very healthy diet. The Mediterranean diet is one of the healthiest diets in the world. And for blood pressure, what we support is the DASH diet. The American Hypertension Association supports the DASH diet, and that it sounds like a dash of salt. I don't know if that's why they named it that. I'm told no. But it's basically a 3,000 milligram per 24-hour or less sodium diet. And if you look it up, there's great recipes. There's great ways to substitute for salt, good foods to choose from that have good flavor without all the salt. And you can certainly use other spices like lemon pepper, garlic, paprika, any other spices, just not salt.
Okay, very good. I just wrote those down too. There's my number 2 or number 3. I've lost track now how many things I'm learning about tonight. Other questions? Okay, I think we have addressed all of our questions tonight, which is perfect timing because we are getting around to wrapping up this hour. And it has been a long day for you. So I'm going to say thank you until I see you in a couple of weeks. We really appreciate it, as always, because and I know people will watch this after the fact and will have a lot of their answers and concerns addressed. And I like your answer of really looking for that aortic disease center, because it is all encompassing. It's like a one-stop shop, and everybody then talks to everybody on the team, which I think is very valuable. I know from personal experience. So thank you so much, Dr. Fisher, for joining us tonight and on our very last night of Aortic Disease Awareness Month. And I look forward to talking to you in the new year on this. I'll be seeing you in a couple weeks.
And if I can give one more plug,
please.
You are survivors, right? So you want to address your health concerns and you want to live your lives. And the whole point of why we do all this work and work so hard to get you comfortable, healthy, is so that you can be healthy. And so that you can do the things you want to do, is so that you can be at the family event. So with COVID, we want you to take all the precautions. We want you to get vaccinated, but we also want you there.
Yeah, that's a really important part. That's true. Yep. Good advice. Good stuff. Thank you so much.
You're welcome.
Have a wonderful evening.
Bye.
Take care, everybody.